Good evening, and thank you for joining us. Welcome to today's webinar. My name is Russ Rowan. I'm the Director of Marketing here at Osteogenics Biomedical. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we'll try to get them answered during the webinar. Now we'll introduce tonight's presenter, Dr. Thayer Alqadoumi. Dr. Alqadoumi graduated from the University of Jordan in 2012, earning his first DDS degree. Dr. Alqadoumi continued his dental education in the United States, where he attended Loma Linda University in California. In 2016, he received his second DDS degree and continued his postgraduate training at Loma Linda University, where he received his MS degree in Periodontics and Implant surgery. Dr. Alqadoumi is an assistant professor at Loma Linda University in the Advanced Periodontics and Implant Surgery clinics. He is also a member of numerous associations. Outside of dentistry, Dr. Alqadoumi enjoys watching sports, playing soccer, traveling, and spending time with his family. We're honored to have Dr. Alqadoumi spend some time with us tonight. With that, I'll turn it over to you, Dr. Alqadoumi. Thank you.
Thank you very much, Russ, for this kind introduction and for the invitation. Thank you, and thanks for Osteogenics for this invitation. Good evening, everyone. We will spend the next hour talking about hard tissue augmentation in preparation for implant placement. This is my social media. I would love to communicate, connect with you. If you have any questions, I'm more than happy to help. So what do we want to learn today? We would like to understand the socket healing biology. We want to define alveolar ridge preservation and GBR. We want to see what are the hard and soft tissue requirements that we need around our implants. We want to see what does the literature say about that. In addition to, we want to classify the sockets and the ridge defects, look at what grafting materials and membranes options we have, and review clinical cases, where I'll try to spend most of the time trying to show you as many cases as possible in order for me to help you get the maximum benefit out of this. So nowadays with implant dentistry, there's a lot of changes in implant placement. We're not doing what we used to do before, which is to place the implant where the bone is. And now it's a prosthetic procedure with a surgical component. So we would like to know where the crown is and accordingly place the implant. That will entail that maybe the implant might be out of the bone housing or some of threads exposed or very thin bone that may cause problems along the road. So we want to make sure that we manage the hard tissue and the soft tissue at the time we're preparing for the implant placement to prevent any future problems. Now, looking at anatomy, we know that we have the basal bone that develops with the formation of the mandible and the maxilla. We have the alveolar bone or the alveolar process that houses the teeth in the oral cavity. And last but not least, the bundle bone, which is a very important aspect that we'll discuss in a little bit, which lines the alveolar socket and it extends coronally to the buccal bone, to the crest, and it makes attachments to the final terminal branches of the periodontal fibers. Now, in this study, and we look at what happens after we extract a tooth, there are a lot of studies out there, but this one comes to explain what research has showed us, and I'll get to that research, but we know we have two phases. Initially, blood clot forms, and that is replaced with granulation tissue, provisional matrix, and woven bone up to 3 weeks. And the bundle bone that I just discussed is completely resorbed, causing a lot of vertical ridge reduction. The second phase is when the buccal wall and the woven bone, they remodel further and causing horizontal ridge reduction and some vertical ridge reduction, and that's by 15 weeks. So when we do the socket grafting or alveolar ridge preservation, what we're trying to do is we're trying to minimize as much as we can the second phase, the horizontal ridge reduction, with a little bit and some of the vertical component. So what is alveolar ridge preservation? It is any procedure that we do at the time of the tooth extraction where we're trying to preserve hard and soft tissue in order for future implant placement or even pontic site development. If we're planning to do a fixed partial denture in the future or later after we extract the tooth, we want to make sure we prepare the pontic to receive the FPD later. What about guided bone regeneration? This is after the fact. Tooth has been extracted, we have a deficiency in the bone, and now we want to grow the bone using a barrier membrane, as you can see in the slide in letter B figure. This is where we want to have the membrane guide the growth of the bone in the insufficient areas and where we need the bone. So what do we know from the literature? A lot of studies from Araujo and Lindy, and this could be the most cited article and the most important one, which discusses the two phases that we talked about in the review before, where we have two phases. Phase 1, we lose the bone and we get most of the vertical bone loss, and phase 2, where the horizontal and the outer surface of the bony walls resorb. They did a lot of animal studies, Araujo and Lindy, to see what if we place the implant immediately at the same time? Would that prevent the ridge reduction? And that failed to preserve the bone dimension after we extract the tooth. What if we place a material with incomplete resorption like a bios collagen? Would that prevent it? It did a great deal in modifying and counteracting the ridge contraction, but at the same time, it did not prevent 100%. What if we use autogenous bone? Same thing. We're still going to lose some bone and some bone width. What if we look at human studies and do an alveolar ridge preservation in fresh extraction sockets? We still get ridge reduction. Then why do we preserve the ridge? Because still what we do with the ridge preservation will be way better, and we reduce a lot the ridge resorption if no extraction was done, and we're going to review a lot of studies that talk about that. So Tan et al., they did a systematic review, and where they looked at the data that we have, we see 29 to 63% horizontal bone loss after we extract the tooth, and 11 to 22% vertical bone loss. That's by 6 months after the tooth extraction. So that's a lot of change in the hard tissue component that will follow by losing soft tissue component too, that will follow the bone. Another study by Schrupp and others where they look at 12 months healing, and they found that 50% of the width is lost by 12 months, and 2/3 of that happens in the first 3 months. And keep in mind that's happening in the mandibular molar region area. So imagine what we're going to expect in the premaxilla in the aesthetic area. Another study now looking at the soft tissue by Alberto Monja and Gonzalo Blasi, looking at how important is it to have keratinized tissue around the implant, especially if the patients are not following maintenance protocol really well. We see more pre-implant disease if we have less than 2 millimeter keratinized tissue. Another group from Garpur, they look at the thin phenotype and the role of having keratinized tissue also around the implant. We see more pre-implant disease and or pain and discomfort during brushing. Dr. Tavelli group, also they look at the peri-implant phenotype, and whatever technique we use for soft tissue augmentation, it helps with the marginal bone level stability. Mariano Sanz and others from the Osteology Consensus Workshop, having reduced keratinized tissue, we see more biofilm accumulation, soft tissue inflammation, more patient discomfort during brushing, more recession, and increased risk of peri-implantitis. Now, what do we know from Danny Boozer group and Chup Wee about the premaxilla area and the thin bone? Generally speaking, we have 0.8 millimeter bone thickness or bone wall width in that area. And after 8 weeks, we see around 7 millimeter bone loss on the vertical height by having a thin wall phenotype. So if that's the majority of the cases, then most of our cases, they go a lot of vertical resorption after we extract the teeth if nothing was done. Now going next, this is a very, very important article by Gustavo Avila Ortiz and Hombley Wang group that if you take home, I would love you to take this article home with you, where it talks about the rule of two. Natural teeth and implant, they behave differently. Fibers around teeth, they insert on the root surface perpendicular. Implants, fibers that run parallel to the implant surface. We have attachment around teeth. Around implant abutment, we have what we call an adhesion. So what are the requirements that we need around the implants? We would like to have 2 millimeter of keratinized mucosa from the mucogingival junction to the mucosal margin. We want to have 2 millimeter of bone thickness. We want to have also 2 millimeter of soft tissue thickness. And there's a lot of studies from Dr. Tavelli group where they talk about the importance of the thickness. In addition to, last but not least, 3 millimeter of supracrestal tissue adhesion. And as I mentioned, it is an adhesion, not an attachment. Now, we extracted the tooth, we did ridge preservation, and in this study we use FDBA. When can I go back and place the implant? So looking at early as 3 months and at 6 months. There is no significant difference if you go by 3 months or 6 months looking at the vital bone amount or the amount of the residual graft. So if you want to go as early as 3 months, there's no problem by placing the implant at that time. What about if I wait 1 year? Would that change the ridge dimension? Would I lose the bone graft that I did? And this study in 2022 by Allen and others, they did a CBCT study evaluation. They compared 4 months and 12 months, and we don't see significant difference between both groups. And you can feel comfortable up to 1 year, but to my knowledge, we don't have any study that discuss what happens 2 years after, 3 years after if we don't replace with an implant. Now, let's look at the sockets, and we want to know what type of sockets we're dealing with. In this classification by Elliott and others, we have type 1, where the hard and the soft tissue where they need to be. Type 2 is when we have bony dehiscence, and the soft tissue, it's where it needs to be. Type 3 is when I have a combination of hard and soft tissue deficiency, and this is the most challenging one to tackle. When we get to ridges, Siebert classification, we have class 1 if it's a horizontal problem, class 2 if it's a vertical problem, class 3 if it's a combination between horizontal and vertical, and that's also the most challenging to treat. On the other hand, Homlewang and Khalaf al-Shamri in 2002, they implemented this classification that is kind of similar to Siebert by horizontal, vertical, and combination, but further classified it as small, medium, and large, being less than 3 millimeters small, 4 to 6 millimeter as medium, and large being more than 7 millimeter. Now we know the socket, we know the ridge. What about the flap? What about the tissue that surrounds my bone? This classification by Urban and others in 2022, they made it just to give a quality for the flap type around the mental nerve during dissection. So if I want to use that, we have class 1, which is when we have native periosteum, clean, no problems, that's easy to release. Class 2, when we have mild fibrosis, some scarring from previous procedures, and that's moderate. And class 3 is the most difficult, thick, fibrotic, and may have foreign body embedded in it. Now, the most important principles of GBR by Homlewang is the pass principle. And we want to make sure that we have primary closure, and that should be tension-free. We want to have angiogenesis. We need enough blood supply. We want to have space maintenance and stability. And let's dive into these. So primary closure, and when we mention tension-free, we always do double layer suturing. And when we do that, the way that I know that I have tension-free is when I see the edges of the flap evert or almost kiss each other by the time I do my first layer of horizontal mattress. Then I know anything I put over the crestal part of the flap will be just holding things together without any tension. Angiogenesis, we get blood supply from adjacent periosteum, flap, or we can do some cortications in the bone. It's controversial about the benefit, but it's going to take me 10 more seconds. It's not a problem. I always can do that. Stabilization, we want to make sure that bone is stable, membrane is stable, it's not moving around. So we can use tacks, and that's one way of stabilizing the membrane. We can use screws, and that's another way. And last but not least, we can use periosteal sutures to stabilize the membrane. Now, what about space maintenance? We can maintain the space by either modifying the biomaterial, maybe adding some xenograft, and we'll discuss that, material with incomplete resorption, or we can use a tenting screw to help us maintain the space, or use a titanium reinforced PTFE membrane, or we can use the same membrane but it's the perforated one, or we can use titanium mesh or a 3D printed tie mesh. Now, what options do we have for grafting? Due to time limitations, I'm going to quickly just touch on each one of them. But autogenous, we're getting it from the same patient. It has osteogenic potential, which means that it will produce bone cells on its own. Allograft, that's donated from human cadavers, that can be FDBA, DFDBA, and the allografts, what we would like from them is to induce bone and be an osteoinductive. So what they do is they're telling the neighboring cells, hey, go ahead and start producing osteoblasts and produce bone for me. Meanwhile, the xenograft that we can get from porcine, equine, or bovine, their main aim is to act as a scaffold. So what they're doing is they're just saying, I'm going to stay here, hold the space for you, you bring the bone whenever you want, I'm going to stay here for a while. Alloplasts, those are synthetics. And last but not least, biologics, we have BMP2, RHPDGF, and enamel matrix derivative that can be used. Okay, now what about membranes? So we want those membranes to be biocompatible. We want them to maintain the space, as we mentioned. We want them to be cell occlusive. This is a very important property that we will discuss later. We want good handling properties, and if they are resorbable, we want good resorbability over time and easy to remove. So the non-resorbable ones, they do better job on maintaining space and doing larger bone formation, especially in the vertical height. They may have higher complication rate, and we'll discuss that, and they require a second surgical procedure. Meanwhile, the resorbable one, they have less complication rate, they resorb faster, and they have better soft tissue response. But the problem is they do not promote structural support. And they can be cross-linked or non-cross-linked, and that cross-linking will determines the resorption time of these membranes. Meanwhile, the non-resorbable membrane, they could be expanded PTFE, the Gore-Tex, we'll discuss that, DPTFE, the dense PTFE cytoplast, and that could be with titanium reinforced or a titanium mesh. So what is the history here? So 1980, Gore-Tex hit the market, and it was the best membrane that everybody was using at that time, but it had a lot of problems when it gets exposed with infections. So they started looking at something else, and Tefgen in 1994 came out with a smooth surface of dense PTFE. And the last one that is the one we use the most is the cytoplast dense PTFE, and that could be titanium reinforced too. So what are the advantages of the dense PTFE? We do not need to have primary closure over the dense PTFE, and that is true whether it has the titanium or not, as long as it's the dense, it's not the perforated one. So that will preserve the interdental papilla, preserve the widths of keratinized tissue, and we'll discuss that. And we have less issues and concerns about bacterial contamination. Even when you're gonna want to come back to remove the membrane, which we want to remove that membrane 4 to 6 weeks after the ridge preservation, there is no need to numb the patient, no need for anesthesia. It's an easy, quick procedure, as I'll show you in a minute. But it is highly recommended that you remove it 4 to 6 weeks, because if you leave it longer, that may lead to apical migration of the flap. And as you can see here, we look at the membrane. You can see the part that is exposed to the oral cavity is dirty, and I'm happy that's telling me it's preventing the gunk from going down there. We just stuck the probe underneath and pull the membrane up and pull it with the column plier. And we see nice, dense connective tissue with some mineralized matrix that, as the next study by Krauser showed us, that doing scanning electron microscopy, we see that the inferior surface of that membrane is clean of bacteria. The superior surface had a lot of colonies of bacteria, and they found dense connective tissue with some mineralized tissue underneath it. A lot of studies, they talk about the benefits and the use of the DPTFE for bridge preservation, where we get more keratinized tissue and more vertical bone level gain in comparison to not doing anything. Another study by Dr. Eliane Barboza, where she also discusses the benefits in terms of the gain of the keratinized tissue, where we see 6.6 millimeter gain in 90 days. Meanwhile, the control group that did not have the DPTFE membrane had an increase of 1.4 millimeter. So we see a significant difference increase between both groups. Another study where I love this study because when you have a buccal bone wall deficiency and it's blown out, the dense PTFE in the study, they compared that what if we use it in an open healing concept, or if we do a GBR like how we're used to do, would we get similar results? And the histomorphometric evaluation showed no significant difference between both techniques, and both were effective in getting back the bone, getting back the buccal plate, and being able to place the implant with no issues. Now, let's discuss some cases. So here, for this case, tooth number 30 needed to be extracted due to endo problems. We extracted the tooth, and this is the image that I want you to keep in mind. You want to place your allograft or biomaterial in the socket. Your dense PTFE membrane has to extend beyond the edges of the bony walls of the socket, 3 to 4 millimeter, and then your sutures, they go on top of that membrane. Make sure it's not touching adjacent teeth, and this is how we look. We place the membrane, we cut it, trim it not to touch the adjacent teeth, and we suture using glycolon sutures in this case. So this is how we look at 1 week. I want to show you what to expect when you encounter this in the clinic. This is when we remove the membrane. This is what I would love to see all the time and every time. But do we see it all the time? Not necessarily. Sometimes you may see some bony particles are still stuck to the on top of that dense connective tissue. It's not a problem. You can rinse it with saline. Nothing to be concerned about. But this is what typically we see, and I'll show you in the other cases. So patient comes back 4 months after. Nice ridge, width and height, good keratinized tissue, good regeneration, and we place our implant where it needs to be. We do a 1-stage implant placement. We suture, and we send back the patient to the restorative dentist. And this is how she's looking 2 years after. Nice tissue, nice bone regeneration that we got for that implant. Now let's get a little bit more advanced in the extraction sockets, where we have this case where the tooth needs to be extracted, and we extracted the tooth. I attempted to do immediate implant placement. I always try to do immediate implant until proven otherwise, or I'm not able to. And I tried to do a provisional or a customized healing abutment unless I'm not able to for many reasons, whether the patient refusing, does not want to spend more money on it, or if I don't have time for some reasons. Private practice life is a little bit different. So that's when I feel more comfortable using this cytoplast membrane, and I'll mention that later in some other cases. So in this case, we were not able to place the implant, but we have a buccal vertical bone loss, a deficiency on the mesial root, more severe than it is on the distal. We place the titanium reinforced PTFE membrane, and remember this is the dense and allograft, and we suture with cytoplast sutures. You can leave it open healing. No worries, and ask me how I know that there's no problem. I'll show you other cases. So patient comes back. We've regenerated good on the width and height. We have nice soft tissue. We have good bone by 4 months. We place the implant where it needs to be, single stage, and we send back for the restorative dentist. Another case with tooth number 29, and adjacent tooth number 30 is an implant. So that creates some challenge, especially when the buccal wall is almost completely gone to the apex. And this is when I do a little pouch. We try to avoid flapping near the implant. And we place allograft, titanium reinforced PTFE, and we suture. And patient comes back at 10 days. This is how it's looking, nice and clean. And at 5 weeks, this is what I see. So you can see some bony particles over the dense connective tissue. You can just flick these away. You see some apical migration of the tissue, which is possible. That's why don't leave it very long. I go at 4 weeks, but if you go up to 6 weeks, you should be still okay. So we've regenerated the bone. 4 months, we go back in to place the implant. And we want to make sure we spare the adjacent tooth implant. We don't want to open it. We place the implant where it needs to be, and you can notice how we gained vertical bone up to the crest of the adjacent tooth and a single stage. And this is how we're looking 3 years after. We're looking at the implant on the far right side of this periapical x-ray. Now, another case where teeth number 12 and 13 needed to be extracted due to perioendo lesions. A patient would like to hold on to tooth number 14. So we extracted the teeth, buccal defect, and we see intrabony defect also on number 14. And as a periodontist, I would like to treat that at the same time. We clean it, we graft with allograft. I place amnion corian over the part where the defect was on the tooth because I don't want my PTFE membrane extending over that tooth. We want to create some room. And we suture with cytoplast sutures. No need for primary closure. Come back and remove it at 4 weeks. Dense connective tissue underneath. And this is at 4 months. We've regenerated good bone. Now we're ready for our implant placement. And this is at the time of the implant placement. We place both implants. We have nice bone on the buccal. We're trying to follow all the rules. And we close it back. And then I'll do some soft tissue management at the time of the uncovery. Another one where this tooth needed extraction, and clearly you can see it is cracked. But the problem is after we extract the tooth is we have no sinus floor. And that's when I say, okay, that's my chance to elevate the sinus because I know I need sinus augmentation later at the time of implant placement. And we use amnion corian membrane, attach it to the sinus membrane in there, and then I use Z-core sinus, expand inside the sinus, and then I place allograft on top of it. And then we close it. We use cytoplast TXT200 membrane and cytoplast sutures. And this is how we're looking at 4 weeks after when we remove the membrane. And this is what we see on the CBCT, and patient is ready next to come for the implant placement. So I made the procedure easier by doing what I did. So when the patient comes back, I have enough horizontal and vertical bone height and good soft tissue in order to be an easy, straightforward implant placement without any complications. Now let's get to immediate implants. For example, this patient needs this tooth to be extracted. And as I mentioned, all the cases that I'll show here with the immediate implant placement, they will be with membrane, no provisional, no customized healing abutment. That doesn't mean that this is what I do all the time, but as I mentioned earlier, it depends on the case. So we section the tooth, we take the tooth out, we give the patient the gold crown because she can sell that. And here in this case, we did the osteotomy through the root just to give me some guidance. We place the implant and we place allograft, fill the gap, and a cytoplast membrane. Comes back after the healing, and we will show you how it looks. Looks nasty, not clean on the side that's facing the oral cavity, and I love it. I know that this is preventing all the stuff from going down, and this is what I see when I remove the membrane. This is what I would love to see all the time I remove this membrane. We see nice, dense connective tissue underneath. And this is the membrane. You can see the sides that are tucked in. They're white, they're clean. The side facing the oral cavity is not clean. And if you look, it's a mirror image. If you look on the interior surface, it is clean. There's no bacteria or any discoloration. So we flap it and we have a problem. We have to look for the implant. That's a good problem. So we flap it big because we also had to place implant on 31. That's not our topic, but we have regenerated good bone, and this is ready for restoration. Now, another one for immediate implant, which this is more complicated, that we have a buccal wall and palatal wall near that canine with bone loss. And this is honestly where I was concerned what to do. I was like, okay, I'll use the titanium reinforced PTFE membrane and suture it and see how that heals. And this is the day of the procedure. And this is how the healing is going. And patient comes back for the uncovery. This is what we have. So we were able to regenerate the bone from where we started to today with just a simple procedure as this. Meanwhile, before, that would be more complicated type of procedure that I'll need to do in order to gain the bone back. Now, as a periodontist, I would love to address the soft tissue more on adjacent teeth, but not every patient walks through the door, agrees sometimes to do more soft tissue augmentation, but this is how we send the case back to the restorative dentist. So from here, we gain the bone here, and we're looking stable, we're looking good. This one, tooth number 13, same thing, immediate implant placement with buccal defect. And we use titanium, we use the cytoplast membrane, and we suture. And patient comes back for the uncovery. We have regenerated the buccal bone. Now let's discuss another case where this patient was not happy about tooth number 7, crown fractured. Tooth number 8 had a periapical problem, needs to be extracted. And this is what we found when we flap it. And also from data from the CBCT. Unfortunately, I was not able to find the flash drive that the patient brought the CBCT with her. But this is what we have on that implant. So most probably that older implant was placed and the apical part was out of the bone when that happened. So it's not a disease. So what we do, we just clean, remove all the soft tissue tags. Here I used Z-Core Z-Form, and we place it over and a collagen membrane laid over it. We place the implant and we suture back using glycolon. And by doing the submarginal incision, we left everything intact for the papilla on the teeth. And we gave the patient Essex retainer, and we placed cytoplast membrane and sutures. So patient comes back for the day of the removal of the membrane, and same thing, we just get the perioprobe, tuck it underneath, no need for any anesthesia, not even topical gel. If you have a super sensitive patient, you can use topical gel, but generally speaking, it's not a problem. And we tuck it under, pull on it, and then bring your cotton plier and just pull the membrane out of there. And you will see, maybe I still have some bone particles underneath, but still I see the dense connective tissue under. You can flush it and then move forward from there. Okay, patient comes back, ready for uncovery phase. And we have nice bone on the buccal. And we place the healing abutment and we send back to the restorative dentist. Now we have good hard tissue, nice soft tissue thickness. We save the implant adjacent, and now it's sent for the restorative dentist to replace both crowns. Now ask me how I learned that I can use the titanium reinforced PTFE in open healing concept. So this case I did in my first year of residency, and we needed to extract those 2 premolars. And as a first year resident, not much of experience, we take out the teeth, we have a huge buccal defect where tooth number 12 was, a little bit on number 13. And we use a titanium reinforced PTFE, allograft, and we stabilize it with tacks, and we suture. But you can see how very sloppy the sutures were that time. I did not get tension-free primary closure as I should. So patient comes back at 3 weeks. So I see that. And I was happy because I love to have complications. That's how I learn. But then I noticed that during 1 week, 2 weeks, 3 weeks, that the tissue was retracting more. So I decided, you know what, I'm just going to treat it like a cytoplasm membrane and just remove it at 4 weeks. And I removed it at 4 weeks, and this is what I found. Nice, dense connective tissue underneath it. So following up 6 weeks, 2 months, just to show you the maturation process, in 5 months. We have good soft tissue, because sometimes when exposure happens, it's good. We get more keratinized tissue. But it's even better if the membrane allows not to have problems or infections. And the dense PTFE is really, really good at that in comparison to others. So we do our planning, and we have nice regenerated bone in comparison to where we started, and considering that it was a complication that I had by exposure of the membrane. And thank you for Dr. Alqadoumi, a great prosthodontist, to replace this case. We have nice soft tissue and hard tissue around these implants. Another case where a lateral incisor is missing with a horizontal and vertical problem. And we can notice we have also fenestration on the adjacent roots of the adjacent teeth. So we do decortications, we harvest some autogenous bone from the chin, we mix it with some allograft, some xenograft. Here at that time we use enamel matrix derivative on the adjacent teeth roots, mix it with the bone graft, and then using a titanium reinforced PTFE, the RPM, the perforated one, and fixate it with screws, and then lay a non-cross-linked collagen membrane on top of it. So this is my release, just to kind of see, do I have enough? And I'm covering the incisal edges, so I'm feeling confident that I can get a good tension-free primary closure. And then we close it, and we come back. And if you look at the CBCT, you can see that even the other teeth, even the other teeth where we added the bone, we have regenerated bone on the adjacent teeth, and I'll show you that in the clinical picture in a second. So this is where we're removing the membrane. I'm going to skip it just so I don't run out of time. And this is the PTFE membrane, the titanium reinforced. Look at the amount of the bone that we got. Got tons of bone. We have regenerated on the vertical and the horizontal. And if you look at the adjacent teeth, also the fenestration that was there is not there anymore because we placed bone graft over these teeth. And we have almost 10 millimeter of horizontal bone. So you can place the implant whatever you want now. So we place the implant, and then we try to manage the soft tissue part by adding autogenous connective tissue graft to get more vertical height and close back. And this is how it looked at the day of the uncovery. Nice tissue, nice thickness, tissue and bone. And this is what I got back, periapical x-ray from the restorative dentist 1 year after. So this is after, and this is before. You can notice the adjacent teeth, also the amount of regeneration that we got on these. Now let's get to a more complicated type of augmentation. That the first one that I showed you now, we can say it's a small horizontal and vertical problem, but this can be classified as a large vertical problem and horizontal too. So here in this case, I'm going to skip that. We harvest autogenous using micros, or sometimes use a safe scraper, harvest it from the area, from the anterior nasal spine, mix it with allograft, some xeno, RPM membrane, titanium reinforced PTFE, and stabilize them with fixation screws. And the part that both membranes are about to touch each other, that is space maintained. It's not a problem. But there's part of the bone particles will have room to fly out. That's when I can add any non-cross-linked collagen membrane without any problem, because it's only for stability, not much for space maintenance. And we lay an amniocorium membrane on top of it, and we go for a tension-free primary closure using cytoplast membrane sutures, and glycolon sutures. At 3 months, patient had that site where it was the weakest point, because patient had extraction, so that was the weakest point to cause problems, and the tissue was not mature enough. So that's where the membrane decided to peek through. And you can see part of the cytoplast PTFE sutures is still there, left in there. That's more anterior. And whoever is following Osteogenics social media, I just mentioned that this is an older case. Nowadays, I use glycolon for my horizontal mattress sutures because I don't want to go back and remove them, because it gets embedded in and it's hard to remove. So now we have a complication. Let's see how we manage. So we open it and I cut back the membrane. I do not remove it, all of it. I just cut back the membrane with scissors or blade, and then I do not remove any granulation tissue, just irrigate it, close it back. If there's any pseudoperiosteum, anything that would like to later on ossify and become bone, I want it to happen. So we let it heal, and we bring patient back 9 months from the day that we did the initial augmentation, 6 months from the day that the exposure happened. So we can see on the CBCT that we have regenerated good bone on the vertical and on the horizontal aspect, considering where we started. And this is how it looks intraorally. We got tons of bone. We're ready for the implant placement. And this is where we started. This is how we're looking at the day of implant placement. And this is where we started. And this is how much bone we regenerated vertically by doing that technique. And if you notice more towards the left side of the screen, the right side of the patient, this is where the exposure happened. So I lost slight vertical bone loss, but it was not a major problem because of how we managed it. So we were still able to get a lot of bone. We were still able to continue the case and move from there. A year and a half later, stable bone, patient is happy. And that sum up today's lecture. Thank you. More than happy to answer any questions you have for me.
Thank you, Dr. Alqadoumi. And we do have several questions. Great, great material, great lecture. Really appreciate you sharing with us. So let's see here. First question. What if you have both the buccal, and I think you showed a case later on in the lecture like this, but if you have a buccal and lingual wall missing, what membrane would you use in that type of situation?
So I'm still, the way that I deal with these, I still use a titanium reinforced PTFE, okay, the dense PTFE, and sometimes I overlap membranes. I know it is not recommended, but I've done many cases where I overlap two cytoplast membranes, and I was still able to regenerate some bone. I know now we have the longer cytoplast. I don't know if we have the 12 by 30 titanium reinforced cytoplast, but if that's the case, that's an option. Then you can tuck it towards both sides, and this way you manage both buccal and palatal. Whatever I can gain out of that procedure, I will take it by 4 to 5 months after. And if later I need to add any augmentation at the same time of implant placement, I will still do it. but it's going to be easier for me than if I would initially leave the defect with buccal and lingual wall or palatal wall defect and try to regenerate later.
When you just now talked about the double membrane, do you mean PTFE with collagen underneath or on top, or are you saying double membrane as in two cytoplasm membranes overlapped?
Two cytoplasm. I use two cytoplasm membrane. I call it
They
door
look
to
like
heaven technique.
great. Well, you use a lot of allografts apparently in these cases, as do a lot of our customers. What are your what when you're using allografts? Are you using a combination allograft, or are you using 100% cortical allograft? What do you prefer, or what's your decision process there?
I use 70/30 cortical cancellous allograft.
Okay, great. Um, this question's a little bit vague. I think I know where they're headed with it, but it says collagen membrane versus PTFE. Your thoughts on using one over the other? So I think the best way, the best probably to cover all bases is, when do you choose to use a collagen membrane versus a PTFE membrane? And outside of that, if someone wanted to try this exposed technique with a collagen membrane, what are your thoughts on trying that or using a collagen membrane instead of a PTFE membrane?
Got it. Very good question. Now, if the bony walls are intact, there is no problem by doing open healing, whether you use a collagen membrane or you use a PTFE. But this is how I look at it. Now, we know with the oral cavity and the enzymes in the oral cavity and everything, that collagen membrane is going to resorb quick if we leave it exposed. So the protection that I'm getting over my graft, I feel personally might not be as good as what I would get by using a dense PTFE membrane that is preventing that interaction between the oral cavity and my biomaterial. That's one. Number two is if I have a buccal wall defect, I used collagen membrane, but I had to elevate the flap, release it, and tend to get as much as possible primary closure or almost primary closure. And we have regenerated the bone, but then I end up with more soft tissue problem later on that I have to deal with. We move the mucogingival junction, the keratinized tissue that we have are less, and then we have to deal with soft tissue. In addition to it's more surgical time. So if I can do something that will allow me to have less surgical time, and at the same time with good predictability, I would do it. Now, don't get me wrong. That doesn't mean don't use collagen membrane, but at the end, you can. There are multiple ways to do a surgical procedure. You can get 10 surgeons, 10 they do it in 10 different ways, and they may end up with the same result. But how did each one get into that result is what is important, what your comfort level is, and what you feel happy with, and with decent results.
Understood. Question about the amnion chorion membrane. Is that interchangeable with a cross-linked bovine collagen membrane? Yes, no. If not, can you just discuss the differences that you've seen between maybe a cross-linked membrane versus that amnion chorion membrane?
Okay, so we're comparing apples to oranges over here. So one is amnion chorion from the human placenta with growth factors and does not promote stability, and it's different completely than a collagen membrane that is cross-linked that has some sort of better space maintenance in comparison to the amnion chorion. So the cases all where I used the amnion chorion, the main aim is to up the regulation, up the growth factors, help with the healing, whether it was with the sinus or over the GBR site, over the titanium reinforced PTFE, and that was the main reason. Trying to use a cross-linked collagen over the PTFE membrane might be an overkill because it has a longer resorption time. I would want to have a membrane underneath that will allow for that partial permeability, so we're not completely blocking the blood supply to the graft.
Understood. So basically, the two products are used in your practice. They're used for two different results or two different reasons.
Yes.
Okay, understood. Let's see here. Kind of while we're talking about the collagen membranes, I'll ask this question, then move on to another topic. But do you use cross-linked collagen membranes? If so, which brand? And I think this kind of leads. The question wasn't asked, but I think it'd be good just your commentary on cross-linked membranes versus native collagen membranes. I think that there's always conversation about that.
Sure. So honestly, I don't use much of cross-linked membranes. I mostly use non-cross-linked, especially if I'm doing horizontal GBR. And I try to get the space maintenance from the xenograft. I mix xenograft in my biomaterials. So I don't use much cross-linked collagen membranes.
Okay. And you just alluded to it, but the question was, when do you use xenografts versus allografts?
Great question. If we are talking about sockets, alveolar ridge preservation, I will use xenograft, not alone, xenograft collagen, that mixed with collagen. For example, like the Z-Core form that I showed over here, or previous, like one of the studies, the Bios collagen. I would use those only and only if I know that the patient is not ready yet for implant. And I've had patients who are like, oh, I don't know when I'm going to be ready. And she came back 2 or 3 years after. So that's when I will use it, because it has slow resorption time in comparison to the allograft. If I want to go in soon, then I'm using allograft. If I'm doing pontic site development, I'm using xenograft. Now, when we talk about the ridge augmentation, if I'm using a titanium reinforced PTFE, I'm not too critical about the xenograft. I may add it. If I don't add it, if that day the office does not have it, I don't lose sleep, because I'll get space maintenance from the titanium reinforced PTFE. If I'm using a non-cross-linked collagen membrane, I would love to have 20 to 30% of the xenograft in my armamentarium and in my mix.
Great. We have time for a few more. We got a lot of questions rolling in. Can you just talk about the difference between mineralized or demineralized allograft?
Sure. So the difference is that the demineralized, the way it is processed, we're exposing the BMP layer to try to induce more bone production. Okay, so that's why if you place a mineralized allograft and you place a demineralized allograft and you take X-ray of both, the one that is mineralized, you'll see radiopacity on the X-ray. The one that's demineralized, you're not going to see the radiopacity. But if you come back 4 months after, whatever, and you look at the X-ray and you see the one that's mineralized and you see the opacity, that could be bone, that could be the same bone. But the one that is demineralized and now you see opacity, that means most probably it's regenerating and you're getting the bone back. So the demineralized portion is we're removing and exposing the BMP in that allograft to try to induce cells, adjacent cells, to produce osteoblast.
All right. Can you do GBR procedures with a healing abutment in place?
Great question. I know a lot of surgeons, they do. There are some surgeons that say, I always place a healing abutment no matter what I do. I don't feel comfortable doing that. I believe that I will, if I'm doing a GBR, I will go for primary closure no matter what. And then I will come back later, place the implant, and I will go back for primary closure for 2 reasons. First is that I want to, my xenograft that I have in the mix, I wanted to cook more. That's one. Two is that I would like to come back 3 months after I place the implants to do some soft tissue management, whether doing a free gingival graft or whatever I need to do. I'll have more leeway and better tissue to work with than if I want to do it at the same time of the implant placement. So generally speaking, to answer this question, no, I don't place the healing abutment if I'm doing it at the same time, if I'm doing a GBR.
Okay, great. In the cases where you have the interproximal bone loss, do you use additional materials? And so I think that the question is more. It's not about the more allograft or graft material. It's more about more
Biologics.
more biomaterials. Yeah.
Yeah. Now it's some cases I add biologics. I use the RHPDGF a lot. Some cases, if for whatever reason it's not accessible at that time, I don't use it. But for that one with interproximal bone loss, I didn't use it, and I was able to get good regeneration. Now, how predictable that is, we'll need to do more studies and see how often you can get this out of 10 cases, for example. If I get a 7 out of 10, I'll be happy all the time.
Gotcha. Got about a minute and a half left here. Good question here. Is an amniotic membrane a better or equivalent solution to PRF-based approaches? Comparing healing times, types of cases that you had used the product in, etc.
Great question. Honestly, I have not used PRF a lot. I know there are people, they swear by it. But generally speaking, for me, I mostly, if I use any, let's call it growth factor type of kind of membrane, I'm using the amnion chorion membrane. But I can't answer which one is better. Even with research, we know that the PRF, most of what's doing, it's just on the soft tissue healing. We don't have much data on the hard tissue healing and if it has any effect on the bone. But I can tell you they both work great. Whatever works in your hand, both should be good.
All right, last question. When you use PTFE membranes for grafting at the time of implant placement, do you remove the membrane 1 month after the surgery, or do you remove it at the second stage of surgery?
No, I remove it at 4 weeks, 1 month.
Okay.
The same concept that you do at socket preservation is you do it at the time of implant placement.
Fantastic. Well, that concludes our time, and great questions from the audience. Really appreciate the questions. It's the most questions we've gotten in a long time on one of these webinars, which is great. So fantastic presentation. Really appreciate you taking the time, Dr. Alqadoumi. And we will look forward to seeing everybody on our next webinar. Thanks, everybody, and have a great night.
Thank you very much.